are proliferative agents, and that is the one who is causing the prostatic hypertrophy and possibly prostatic cancer, and possibly not just prostatic cancer, but what we call estrogen dominant syndrome, when you have excess of estrogens and you don't have enough of progesterone to put the brake and differentiate those cells that's being proliferated by the influence of estrogen, excess of estrogen, then it may lead to colon cancer, breast cancer, and maybe all the cancers. Possibly it's because of the excess of estrogens. We call it estrogen dominant syndrome. So from here, I think we need to learn that for this patient who has low testosterone, which is 12, in order to give him testosterone without causing him or causing hypertrophy of the prostate and going to the bathroom and it's bothering him, of course, is to give some sort of aromatase inhibitor. And the best aromatase inhibitor is progesterone because it's more natural. So progesterone with testosterone, we topical cream we can do it in a ratio of 10% testosterone, 1% progesterone. And for the female, we can do 10% progesterone, 1% estradiol. I think those are a good thing. So that we have progesterone that helps to inhibit the aromatase inhibitor, to inhibit aromatase and prevent the conversion of the testosterone to estrogens and prevent the excess of estrogens, which is the problem, which is that it's causing this um, hypertrophic and proliferative effect, and possibly cancer and inflammation. Estrogens, excess of estrogens, and estrogen dominance, it leads to inflammation. It's more worse than cortisol. Cortisone is anti-inflammatory and degenerative. Estrone is inflammatory, and you can call it regenerative, but still it's inflammatory, and it can lead to cancer. So we need to stop that by giving progesterone. Progesterone will have the testosterone converting it to estrogens. At the same time, progesterone will cause differentiating effect over the proliferative effect of estrogen. So it's kind of slowing down the proliferation and allowing the cell to differentiate. Because if you push the cells too much to proliferate, then you don't give them the time for them to build enough of antioxidant machines, and then they will have a problem of neutralizing the free radicals, and they will be source of pathological free radical and source of inflammation.
Can you
And
repeat those doses again?
I think just standard dose, and you can personalize with your patient. In the topical cream for women's, I think we can do 10% progesterone, 1% estrogen, but still, you need to do the lab and see whether you need to personalize it more. But generally speaking, and for the male, 10% testosterone, 1% progesterone. But of course, you can add aromatase inhibitor. I mean, you can see Dr. Stefan. He likes iodine. Yes, iodine. It works like progesterone, by the way. They inhibit aromatase, and also um, it has an antioxidant effect, and so it may reverse the oxidative stress of excess of estrogens. And so, adding iodine as an aromatase inhibitor, if you want to go farther and you add calcium glucarate, then you can go farther and you can do anastrozole, and you can do clomiphene as well, and you can do topical clomiphene 1% and anastrozole maybe 1% topical in case you need more of aromatase inhibitor. But we start with progesterone and testosterone, and then we check after 3 months and see if there is a need of further aromatase inhibitors if the patient is complaining from frequency, or you think that he still have estrogen dominant. You can increase the progesterone, or you can add iodine. And if you're afraid that the patient may have testicular atrophy from inhibition of the central hypothalamus pituitary gonadal axis, then you can go ahead and give topical clomiphene. And if you see that aromatase is still not enough, you can add anastrozole 1%, 1% to your topical cream. And then you have a complete multi, it's not mono pharmacy, it's multi pharmacy cream that contain all those ingredients that definitely help to um, increase the testosterone without the side effects of excess of estrogen. Um, is my screen is on or not yet? Okay, if it's not, then I will just continue
It's
here.
on.
It's on. Okay. Yeah.
That's
So if we can go a little bit low, so we can you can see that this is very important. The pathway of the steroids, and we know that progesterone at the end, or progesterone is the mother of both the cortisone and sex hormones. So progesterone can go to the direction and turn into cortisone, or it can be a precursor for precursors for sex hormone for testosterone and then of course estrogen. And so I like
well, I didn't do it. Is he gone?
I'm sorry for that. Yes, I'm back.
Okay.
Okay, can you hear me now?
Yes. Yes. Yes.
Yes,
We.
yes, we
Okay.
can hear you.
Okay, you can hear me, right?
Yes.
Yes.
I am I. What is this? The screen. Favorite screen. Is that your screen?
It's my
Or
screen. It's my screen.
uh,
You tell me to move it, I'll move it.
okay. No, no. I'm just seeing here. I'm trying to find. Okay.
Everybody should be able to see the steroidogenic pathway,
Yes.
and it
Yeah.
says
So this is
hormones
very
and age.
important. Yeah, and Dr. William, all the time, he's insisting putting this in front of us so we can understand that, progesterone is the mother of the cortisone. I know pregnenolone, yes, but progesterone will be the next, and you can move it either way. You can move it to the sex hormones, or you can move it to the cortisone. It's all about what the body is in demand, and if they need more cortisone, then they will be shifting it to produce cortisone. Um, so so we understand that aging is a complex process that involves many factors, right? It involves hormones. It involves all the toxins that you've been exposed, inflammation, and the underlying conditions, infection, blood pressure, all of this. Sleep, if you sleep very well, definitely will slow the process of the aging. Um, but uh, what's very important is cortisone. Um, Cortisone is a drug that causes anti-inflammation, but also it causes degeneration. And so, at the age of 50, when our sex hormone drops, what will happen is your basic inflammation that's being taken care of by sex hormone is not there anymore because of the drop of the sex hormone. And a patient will, for female, they will have postmenopausal symptoms, which are the manifestation of the inflammation that's being damped by the sex hormone, that's being taken care of by the sex hormone. But system when it drops, and that leads to I don't know what's going on with this.
Do you need Doc to advance the slides? We lost sound again.
Hear me, guys?
Yeah, we hear you. You need me to
Yeah.
move?
So
You need me
why is
to
it?
advance the slide?
Okay. Yeah. You can go ahead and advance the slide. Uh, yeah. So basically, as you see here, that aging, part of the aging is inflammation, whatever that all this environmental exposure that leads to inflammation in our body. Yeah, you can say inflammation is it leads to oxidation, and it leads to aging and damaging, and possibly accumulation effect of all this damage that we are experiencing from the environment. It's part of it. But when we have inflammation as a response to those injury, then we would have cortisone, and then this cortisone will help to decrease the inflammation. But the problem with that, it definitely speeds the process of aging, because cortisone does cause atrophy, does induce apoptosis for your healthy tissue. So, so you have two factors that's causing the aging: is the the inflammation from the toxins that we are exposing from the environment. And we have the response is cortisone, and cortisone is not doing much in other words, it's suppressing the inflammation, but it's speeding up the process of aging. That's why when a patient or person is stressed out, whether from family or anything, any stresses, and his sympathetic goes up, and sympathetic release norepinephrine cause activation of NOx enzymes, generate free radicals, and eventually it's causing inflammation, right? When you're stressed out, your inflammation will go up, and as a response, your cortisol will go up, and then cortisol will damp the inflammation, but it will lead to speeding up the aging process. So if you see those people are being stressed out, they're not sleeping or stressed out for any reason from their job or whatever, their aging process accelerate. And so the idea of be happy, be healthy, and the happiness and all this happy molecule and increasing the parasympathetic and decreasing the sympathetic, decreasing the inflammation definitely help to slow the process of the aging. But at the age of 50, that's the big factor here that leads to really speed up the aging process is when the sex hormone drops at the age of 50. And then because of your gonads not producing enough of testosterone, plus, which we call andropause, or in female menopause, then what would happen is that you would have this flare-ups, all the symptoms of those basic inflammation that's being taken care of by your sex hormone is not there, and it manifests with most postmenopausal symptoms, all this flash and mood swinging because of the inflammation of the brain. Of course, decrease of serotonin, and the women's, they have moody. She will have kind of swinging moods, and that's because of the low serotonins. And of course, the big pharma, the mainstream medicine, they will start prescribing serotonin uptake inhibitors instead of going to the root cause, which is it's because of her sex hormone drops, which is supposed to be having anti-inflammatory effect, and instead of treating the root cause, which is giving her sex hormone, and prevent that basic inflammation from flaring up and decrease in serotonin, because when you have oxidative stress in the brain, you decrease the conversion of tryptophan into serotonin. And so instead of, I think it's better to give or replace the sex hormone so that you prevent that switch from sex hormone dominant pre-50 of age, that switch that from sex hormone dominant to cortisone dominant. And so if we do that and we intervene and we start giving those sex hormone, balanced sex hormone, not mono sex hormone that we're doing, not to give the patient estrogen only or testosterone only, because you will end up with estrogen dominant syndrome and you make the case more worse. Why? Because excess of estrogens leads to inflammation, and then inflammation calls the cortisone, and then you end up with cortisone dominancy. And so you end up with estrogen dominant plus cortisone dominant. So you don't want that. You really want to give the patient progesterone, testosterone in male, and progesterone, estrogen in female. And so if we stop that switch from the sex hormone dominant, which is pre-50, to that switch into cortisone dominant, which is post-50, right? Then we can definitely slow the process of the aging. Because once that your cortisone or your adrenal gland takes over and start taking care of your basic inflammation, yeah, it will take care, and your symptoms of the postmenopausal symptoms will disappear. That's true with time, because cortisone is taking over. But what will happen that women will age faster, right? Because cortisone is taking care for the basic inflammation, but at the same time, it's causing atrophy, and it speeds the process of the aging. So cortisone is anti-inflammatory and degenerative drug. Sex hormone is anti-inflammatory and regenerative drug. So we really need to maintain that sex hormone dominant throughout our lifespan, right? And very important that you give balanced BHRT, BBHRT versus giving BHRT, the regular way or the common way that most of the patients and the doctors prescribe monotherapy of estrogen and testosterone, and that causes a lot of problems. It leads to estrogen dominance. And then when you end up with estrogen dominant, as I said, excess of estrogens leads to inflammation, leads to more fat tissue, It will induce the aromatase, and it will lead to more of estrogens and inflammation, which will lead to calling more of cortisone, and then you end up with estrogen dominant plus cortisone dominant. Now, what is also important to know that if we allow this switch to happen from sex hormone dominant to cortisone dominant, cortisone also induces aromatase. So what will happen? Cortisone dominant will aggravate the estrogen dominant because cortisone stimulate and induce aromatase enzyme. Does that make sense? Cortisone induce aromatase, and that will lead to further conversion of the testosterone into estrogen in male and female, and that leads to further estrogen dominancy, right? And then estrogen dominancy means too much of estrogens because your fat is producing estrogens, the aromatase, and estrogens is inflammatory when it's excess. When it's excess, it's inflammatory agent, and that leads to all the cancer that we know, whether it is prostate or breast cancer, even colon cancer is some of them related to the estrogens. And here this is very important, that progesterone inhibits cortisone-induced aromatase activities. Progesterone inhibits, that's a very important statement, progesterone inhibits cortisone-induced aromatase activities. So progesterone is good for all the way for managing estrogen dominant syndrome, and also it helps to inhibit the cortisone's stimulation or extra stimulation of the aromatase of the fat. So that is now we know that's critical that we add progesterone to your testosterone and estrogen, and it's very important to entertain balanced HRT, balanced bioidentical hormone versus monotherapy of so basically we understand that estrogen dominant syndrome, what is the cause of estrogen dominant syndrome? Well, us as doctors, if we don't understand the difference between monotherapy and combined therapy or balanced bioidentical hormone, then we are in trouble, because if those people who are receiving testosterone only, they end up with estrogen dominant syndrome. And estrogen dominant syndromes can lead to cancer, inflammation, obesity, right? Problem with, and so it could be because of the hormonal replacement therapy that we're doing. So that's one cause. The other cause, yes, polycystic ovarian syndrome. Genetically, they may have problems in the ovaries where they don't see the aromatase of the ovary or the gonads and the testis are different from the aromatase of the fat. That's very important to know, because those aromatase inhibitors, including anastrozole and progesterone, they don't inhibit the aromatase of the gonads, right? And that's very important because we need to keep the aromatase activity of the gonads, especially in female. And if there is any problem with the aromatase for any reason, genetically, then you have a problem with converting testosterone to estrogen. Then the gonads will start producing excess of testosterone, and this testosterone will be converted by the fat aromatase into estrogens, and they will have what we call the polycystic ovarian syndrome, right? And so how we treat polycystic ovarian syndrome, you need to inhibit the aromatase of the fat, and you may need to give some sort of progesterone, because progesterone will help in those patients, because they do have excess of estrogen, and maybe progesterone will balance the excess of the estrogen that is coming from conversion of testosterone to estrogen. So they have estrogen dominancy when you have polycystic ovarian syndrome, because all this excess of testosterone will convert into estrogens, and then you have excess of estrogen, and you have problem with the balance between estrogen and progesterone. That balance needs to be maintained to prevent that excessive proliferation, oxidative stress that's coming from estrogen. Progesterone puts holes on it directly, not just through inhibition of the conversion of testosterone to estrogen, but also directly it slows down, or at least a differentiation effect. So it slows down the process of proliferation, allowing the cells to mature and build enough of antioxidants so that it will not be source of inflammation. Um, the other thing is that if you have too much of fat tissue, then you have too much of aromatase activities, then yes, then you would have estrogen dominant syndrome, because all this fat, which is full of aromatase, they will be converting all your testosterone into estrogen. So a guy with a lot of fat, especially the visceral fat, that's not healthy. The fat is source of inflammation. The fat is source of aromatase that converts testosterone to estrogen. And when you have estrogen dominancy syndrome, yeah, you will have metabolic syndrome and you have cancer. Estrogen, excess of it, can lead to oxidative stress, can cause insulin resistance, and can cause cardiovascular problems and all the thing. So you really need to work on reducing fat. Fat is a problem. Fat leads to metabolic syndrome, cardiovascular, and fat excess can lead to cancer, right? So those people with obese is a risk factor of the cancer. We understand why, because of the excess of estrogens. Estrogens is inflammatory and proliferative, and it induces cancer. And so it's very important that we understand that when we manage and optimize the health, we need to reduce the fat. We need to do weight loss program for all our patients, including ourselves. And there's many things, many ways of doing it. Ozempic is one way, although Ozempic is very harsh to the pancreas, because Ozempic cause some proliferation effect into pancreatic ducts, which may cause blockage of those pancreatic ducts, with the patient at risk of acute pancreatitis, right? I have a friend of mine, um, his wife ends up into ICU because of Ozempic. And so we need to be careful with that drug, and possibly adding things that helps to slow the process of the oxidative effect of those Ozempic, maybe adding NAC, maybe adding thymosin beta, something that helps to neutralize those free radicals. And it's inductive oxidative stress, and they're pushing the pancreas, and they are also generating insulin, part of the mechanism. And insulin spike is not good, because insulin itself is oxidative stress. So is there anything that helps to maintain the effect of the Ozempic after patient has weight loss? Yes, I think we can use acarbose instead. Acarbose inhibits amylase, and yes, it will decrease the absorption and degradation of the carbohydrates, and the carbohydrates will be fermented, become gas. So you just need to give a lot of anti-gas, or you can have a formula that I have a pharmacy. It's called National Pharmacy in California, and if you're interested, I can give you his phone number. I don't know if he's still here in the room. If he's here, he can put his information. But I developed a formulation where there's acarbose and anti-gas drug, whether it's activated charcoal or others, and then naltrexone, DEM inside it. Also, it has amloxanox. I think it has a very nice formula that helps to decrease the weight without the side effects of Ozempic. So it's an alternative to Ozempic. And it has DEM, which inhibit the aromatase and conversion of testosterone to estrogen. It's very important that weight loss, you need to consider estrogen dominance, because they're all interconnected. So if you have too much of fat, you have estrogen dominance. So you really need to have some drugs that inhibit the aromatase as part of your regimen in managing effectively the overweight. So again, it's critical that if the patient has one of the other things that cause estrogen dominance is that they have toxins, plastics that they are consuming. We are actually inside a bubble of plastic and petrochemicals and all this organic phosphorus, and the stress itself. When you're being stressed out and you produce cortisol, cortisol induces aromatase and conversion of testosterone to testosterone to estrogens. So we need to avoid all these toxins. And if you have the toxins, then you need to find out the way to detox your body, especially from all this meat to contain xenoestrogen, which is those foreign estrogens, synthetic estrogens that can mimic estrogens, and they can lead to estrogen dominance. And estrogen dominance is very important. It will cause a feedback inhibition of your hypogonadal pituitary gonadal hypothalamus pituitary gonadal axis, and it can lead to decrease the production of the sperm and the quality of the sperm, because of that. So it really leads to infertility, all these toxins, and it leads to atrophy of the gonads. So um, we need to get rid from those excess of synthetic estrogens that's coming from the environment that we've been exposed to. And I think Dr. Patel has a very good program for that. I think she's using sauna, massage, detoxing. It's very difficult to get rid from fat soluble toxins. Weight loss will be good, but then all this toxin will come to the blood, so you really need to detox them using those chelation activated charcoal, maybe work EDTA, anything that helps to stick with those fats. C60, some of them they say it may help, but when you do weight loss, you really need to put the patient on detoxing process, because toxins that's being released from the fat tissue can harm your kidneys and our patient's kidneys and heart. Um, so I think this is the management that we recommend for both sexes, male and female, and also making sure that you turn or you switch the patient from taking just bioidentical hormones into balanced bioidentical hormones, making sure you check all the six hormones and they're all balanced. And there's a ratio between progesterone and estrogen, right? And I think I wrote the ratio. Can you show them the ratio, doctor, between estrogen and progesterone so they can see it? The normal ratio.
If you do an estrone and estradiol divided by progesterone, we want that to be less than 250.
Right. For
Okay.
both male and female, or female talking about?
No, that's for females.
Okay.
Okay. The male testosterone to estrogen estradiol ratio, you want that to be greater than 20 to 1.
All right. So that's very important, those ratio, right?
Right.
Because just absolute numbers is not going to help you to diagnose estrogen dominance. I think the ratio it's very critical,
Right.
and I think I put there the ratio as well between testosterone and estrogen, and also estrogen and progesterone. Those ratio has to be normalized, because if you have too much of estrogens and you have less of progesterone, then you have more of proliferation, excess of proliferation. It's like pushing the cells to divide without being mature. Then those cells they will not have enough of antioxidant to neutralize those free radicals, so they will be source of inflammations. The other thing it's very important when managing estrogen dominant syndrome is to give the patient probiotics. Why probiotic in the morning? Because we know that those fat tissue in the viscera, they are source of inflammation. They produce interleukin 6, right? Those fat tissue, they are source of inflammation, and they introduce interleukin 6, which means they aggravate any underlying condition. If you have diabetic hypertension, it makes it worse if you have fat, because fat is source of inflammation. And if you have the inflammation will compromise the mitochondria, preventing those fat tissue from burning the fat, from oxidation and beta oxidation, because the mitochondria will be compromised by all this inflammation and free radicals, and especially interleukin 6. Um, so when you take probiotics, especially the one that I recommend from Dr. Hotan, he has this bidiform bacterium in his probiotic, and the bidiform bacterium produces butyric acid, and butyric acid is very powerful anti-inflammatory. It inhibits the Th17 inflammation, reduces interleukin 6. Now listen to this. Interleukin 6 is aromatase inducer. That's very important. So, if this probiotics, which is bidiform bacterium, produces butyric acids, and butyric acid is anti-inflammatory, inhibit the Th17 and lower interleukin 6, then I am decreasing the activity of the aromatase, and I am decreasing estrogens. And we know estrogens is inflammatory agent. Yes, it's proliferative, but it's inflammatory. And when you have inflammation, then what you will have, you will be start calling the adrenal gland to secrete cortisol, and then the cortisol will cause the aging process, be the process of the aging, plus the cortisol will induce the aromatase and cause more of estrogen. So you will end up with a vicious circle of estrogen dominant and cortisol dominance, and that's the problem that we have with aging and stress And that's why we think that be happy, be healthy. That's true, because all these happy molecules, especially those patients are taking mushroom and psychedelic, and they say it's effective. The reason why, because they're increasing their happy molecules, and those happy molecules, they have anti-inflammatory effect by increasing the vagus nerve, and then that vagus nerve antagonizes sympathetic and norepinephrines, which are there are inflammatory signals. They activate the NOx enzyme, and so increasing that parasympathetic due to those happy molecules, oxytocin, CBD, dopamine, serotonin, all of this helps to increase the vagus nerve, and it has anti-inflammatory, reduce the inflammation, and it reduces the cortisol, and then the patient will slow the process of the aging. Sleeping at night is very important, because if you have lack of sleep, then you don't give a time for the patient to detox, because during the sleep we detox from all this extra free radicals, and we balance autonomic nervous system, so we're getting rid from all those free radical generators during sleep. And if you don't have that enough time of sleep, then those free radicals will stay there and induce inflammation, induce cortisone, and you will see that it will speed the process of the aging. So from here we learned that it is very critical that to prevent the switch from cortisone, prevent the switch from sex hormone dominance into cortisone dominance. It is very important to prevent the switch from sex hormone dominance to cortisone dominance in order to slow the process of the aging. And yes, sex hormone is an anti-aging, it's anti-inflammatory. Cortisone is inflammatory. Cortisone is anti-inflammatory, and it's a degenerative. And we need to prevent that switch, because once it's switched, then those cortisone will induce the aromatase enzyme, will cause more conversion of testosterone to estrogens, and then you would have both. You have estrogen dominance, and you would have cortisone dominance. And we know the cortisone dominance feeds the estrogen dominance, because cortisone stimulates the aromatase, right? And then the estrogens will induce inflammation due to its unchecked proliferative effect, where the cells are immature and they start causing inflammation. Inflammation causes cortisol, and then you have this vicious circle, and that leads to speed the whole process of the aging. And we can stop it easily by making sure that the patient is taking balanced sex hormone, making sure we detox the body from all this xenoestrogens, which is the foreign estrogens or estrogen mimics, all these petrochemicals that we're being exposed. I think Dr. Patel, when I went to her house, she doesn't use any plastic utensils. All of it is glass. And the reason why, because she wants to protect herself, because those plastics and those they are aromatase inducers. And aromatase inducers means cancer, means inflammation, means excess of estrogens. And so if we follow all of this guideline, I think we can slow the process of the aging and treat the underlying conditions, whether the patient has diabetic or hypertension or Alzheimer, all of those conditions, right? It can be managed just by managing the estrogen dominant, the cortisone dominant syndrome. Why? Because all of this estrogen excess is inflammatory. It's a free radical generators, and they will aggravate the inflammation. If the patient has Alzheimer, it gets worse. If the patient has diabetic, it gets worse, because the common thing here is inflammation. And one of the ways to manage is to screen all these free radical generators, all this inflammation sources, and try to put them down, put the fire down. And that's the reason why the mainstream medicine, they fail to manage chronic diseases, because they are managing a systemic, and they don't care about other systems. And if other systems are inflamed, or the other system is leaking free radicals, or the other system is generating estrogens, then that neurologist who's trying to treat Parkinson or trying to treat Alzheimer, he will not be able to slow the process of the degeneration. And I think we need to upgrade all the doctors to come up with understanding of how to manage multisystemic disease under the big umbrella, which is called chronic disease prevention and management, which is being entertained by American Medical Association. It happened that I have the same title that I'm entertaining, which is, it could be a medical specialty, because AMA is trying to promote this field, and is asking us to create curriculum, residency, fellowship program of chronic disease prevention management. It's the way that we can manage the disease in a form of multisystemic, in a state of the tunnel vision of the specialist, which is one system at a time. and most of the time they fail to manage. And we can see the failure very clear when COVID hit, and COVID is multisystemic disease. All the specialists are kind of scratching their head and referring it to each other, and the patient got lost between all the specialists. Yes, integrative medicine, the word integrative is a combination of traditional and complementary medicine. But the big pharma, they don't want you to label yourself with the title that gives you or describe how you're treating the patient. They want you to be a healthcare provider, and they're the one who's going to give you the protocols for you to provide it to the patient. And they want you to be labeled by what you are treating. Are you a neurologist? That's me treating neurological diseases. But they don't want you to be labeled by the way or how you're going to treat it, like integrative doctor or holistic. No, right? Because then this will kind of drive. You start doing it more of complementary, less of mainstream, and then definitely you will decrease the revenue from selling their mainstream medicine, which is the big pharma, which are behind it. So they want to make sure that you're doing a lot of mainstream and less of integrative, and that's the reason they don't like those labels. They don't like the label regenerative because you're using stem cells versus cortisone, and so they want you to be labeled on what disease you're treating, and then they will tell you what treatments that you need to provide to your patients. And if you don't follow that, they will definitely step you and take your license or harass you or kick you off from the health system. So this is what we call the money-driven health system and safe medicine, in a state of having something that really for the best interest of the patient, and giving the doctor and restore the physician autonomy. I think that's been stripped out from us. And I did write a book about this. It's called The Deadly Rise of Unsafe Money-Driven Medicine. But hopefully we'll be published it when the system is going to be changed, maybe a couple of maybe less than 1 year, but we're hoping for that the case. So anyway, I think I did summarize everything that's written in this without going through it because I cannot see the screen, and if I start touching it, it disappears, so I cannot read through it. But we can send this copy to everybody here in this room. But if you have any questions, I think it's better to have that discussion. I don't know if Audrey is here. She's promoting exosomes, and I thought we're going to give her 10 minutes. I don't know if she's here or not. That would be a good time for her to come.
I don't know. So, for men, for progesterone, what are you suggesting? Oral or topical?
I think topical would be a good thing, because what I would do is that let's start with testosterone 10%, 1% progesterone, 3 months, see what's going on. If the patient still have too much of estrogen, then you can add more progesterone. If the patient has less testosterone, you add testosterone. And then if the patient, you're afraid that they will have testicular atrophy, you add clomiphene. You can add in the topical cream 1% clomiphene. If you think that you're adding testosterone and still there's estrogen, and the patient is going to the bathroom, and you say, I'm going to add iodine. Iodine is very good aromatase inhibitor. Or you can add, at the end of the thing, you can go ahead and add anastrozole. But before that, try to use other things, and you can add anastrozole 1% topical, by the way.
What
Um,
dose? What dose iodine?
Iodine, I think Stefan is very good at it. I think he's giving 10 milligram, right? Stefan?
Yes, 10 is good.
10 milligram daily of iodine, there will be an optimal level. And then again, just leave the drugs as much as the end. If everything is still, patient is still not still have estrogen dominance, and you want to add anastrozole, you can add topical 1%. You don't even give it orally. I think it's better. 1% will be enough. And then if you're afraid of the feedback in testicular atrophy or gonadal atrophy, then you can add 1% clomiphene topical as well. I like topical, just it's more safe, and the body determine how much it's going to be absorbed, and then you can adjust it, increase it, and you avoid this liver problems, from absorbing it, going to the liver, and then the liver have to be challenged taking care of it with that high dose. So topical goes to the systemic, and maybe it will distribute to the whole body before it gets into the liver.
Somebody in the chat had asked me to repeat the ratios. So
So
estrone.
topical for men, again, I would do 10% testosterone topical with progesterone 1%. For female, it's the opposite: 10% progesterone, 1% estradiol, and then you can adjust it based on the patients, adding progesterone, adding testosterone. That's something you can do, but eventually you can add topical clomiphene in case you're afraid of testicular atrophy or gonadal atrophy, want to keep the fertility going. 1% clomiphene. If you still that there is estrogen dominancy and estrogen is out of control, then you can add anastrozole 1% topical cream, and then you have those four things there. But really, you start with progesterone and see if progesterone with the six hormone will be, because progesterone is both aromatase inhibitor and it antagonizes or in other words, it provides a differentiation effect on the estrogen proliferative effect. So it balanced that, right? And very important to maintain the balance between estrogen and progesterone. What is the range you think between estrogen and progesterone? 20 to 40 to 1, 21, 41, right? That's very important.
Testosterone to
No, progesterone to estrogen in both male and female. What's the best ratio?
estrone plus
Uh, es,
estradiol
es,
divided by progesterone
right,
should be less than 250. If you don't have estrone, then we do a progesterone estradiol ratio, and what you need to do is multiply the progesterone by 1,000 to even out the units. So it's 1,000 times the progesterone divided by estradiol, and you want that to be between 100 and 500.
right,
Less than 100 is estrogen dominant. Greater than 500 is progesterone dominant.
right. I think that's very critical for us. Even for male and female, we need to keep that ratio because progesterone is putting the brake over the estrogens, whether the estrogen that's coming from the conversion of testosterone or from the estrogens of the female. That is very, very, very critical. That and yes, that in male also you need to make sure that your testosterone estrogen ratio is normalized as well. And the ratio is more important even than level sometimes. I mean, normalizing the level is good, but checking the ratio. And I think the best to understand the ratio. I mean, Dr. William, he is the reference for all of this. I mean, I learned a lot from him. I appreciate joining his group because of his confident and insisting and yes, this is it. And he's, fighting 500 osteopathic doctors.
What does progesterone dominance even look like? Has anyone even ever seen that?
The
Well,
only
it's very rare.
time I've ever seen it is with we did it. We induced it. We over treated with progesterone.
Iatrogenically, right?
Yeah,
No.
iatrogenically. Basically, the patients will be sleepy. They'll be kind of loggy and bloated, GI distress, and just sort of feeling like their head's sort of not attached to their body. Okay.
So like pregnancy?
Pregnancy, Logan.
Yeah, because progesterone works like GABA, by the way, and it's a very sedative drug
Yeah.
because it ends up
Now
like
there was
GABA.
early on in the hormone world, there was something called the Wiley protocol, where they used huge doses of progesterone, like 600, 800, 1,000 milligrams, and so we would see these kind of levels. But I think there's a new Wiley protocol that sort of follows the menstrual cycle with the doses now, so the doses are much less. But
so let me add something here very important. From here we can learn that we can create injectables for pain, and there is a study there just to confirm what I'm talking about here. That there's a study for managing carpal tunnel syndrome, and they use cortisone versus progesterone injections. And they find the progesterone injection is more effective than cortisone because cortisone, it is anti-inflammatory, yes, but it's a degenerative, right? And so it causes degeneration of the neurons on the nerves. You don't want that in carpal tunnel. You want to have regenerative and anti-inflammatory effect. So they did this study, and it's double-blinded clinical trials. I think it's there in the text, and they find out progesterone injection is way more effective than cortisol. So from here, we can learn that we can create injectables, and that's what hopefully it's going to be in the future. That we have testosterone 1% with progesterone 0.1 for male, and then female we can do 1% progesterone and zero point 0.1. This I'm talking about injectable, right? 0.1 estradiol vials. And if there's any problem with the fat and water soluble, whatever, because you want to add procaine in it, right? So what you do is you learn how to do platelets nanoparticle, and you take the platelets, you mix it with the 6-hormone, with procaine, with oxytocin, possibly you want to add methylene blue, you want to add B12, you can add anything, and you sonicate it, nanofiltrate extrusion, and then you inject it anywhere you want. And I think this will be the future of medicine, where we use platelets nanoparticle loaded with 6 hormones and any drugs you want. And procaine, I like procaine versus lidocaine because procaine is anti-inflammatory and regenerative. Lidocaine is toxic. See, and so procaine, if you say, oh, well, the big pharma or the mainstream medicine doctor will say, well, procaine has short life. Yes, but if you add it when you clock it with platelets nanoparticle, you end up putting it in the nanoparticle. It will slowly release, and it gives you better effect than lidocaine. So something, if you're interested in training platelets nanoparticle, I will train you to do that. And I did train around 11 doctors. And the platelet nanoparticle is not something I invented completely. There's already a big pharma. It's called Silo Therapeutic in California, but they're stabilizing the platelet nanoparticle loaded with any drug you want with the PLGA. And we know that the PLGA, once you start introducing it, you start forming a drug. But they did it because they need a step for increasing the shelf life of the drug. But for us, we don't need the shelf life because we're not selling it. So something you may consider it when you do this. Now, I just want to also emphasize that in the morning, take probiotic Betiform bacteria. I think Dr. Hotan is here. If he can put his information in case you want a probiotic that helps in managing estrogen dominant syndrome, as we know that the inflammation coming from the fat tissue and interleukin 6 does stimulate the aromatase, and you really need to drop the interleukin 6 by probiotic secreting butyric acid. Butyric acid inhibited TS17, inhibited interleukin 6, and this will decrease the aromatase activities and the conversion of testosterone to estrogen, and it's part of the weight loss. That's the reason why this Betiform bacteria is good for weight loss, because it decreases the inflammation, it decreases aromatase activity induced by interleukin 6. Right, and we know if you have inflammation, then you will have cortisol induce the aromatase, you end up with that vicious circle going. So taking the morning probiotics rich with Betiform Bactrum, I think Hotan is here, maybe he will share with you his information, and then doing diet capsule with acarbose and dem and amloxanox. I think it's going to be a metformin alternative to Ozempic, and more safer because you're not putting any pressure, and you're not allowing the sugar to go in, because sugar is oxidative stress. Insulin is oxidative stress. You really don't want sugar and insulin to go up, and that's what Ozempic does. I mean, Ozempic does increase the insulin, and insulin is a free radical generator, so it's not that much of health comparing to something you stop the absorption of calorie. I think that's the best option to do. And at night, I want everybody to be in detox, right? On the activated charcoal, C60, there's carbon 60, also it's a detox, zeolite, carnosine, very important. Carnosine inhibit the glycations, right? Especially in patient with diabetic and EDTA. And if you follow this, then you definitely have a complete program for weight loss that include decreasing the fat and decreasing and managing estrogen dominant syndrome and managing the metabolic syndrome, because all those three things, metabolic syndrome, estrogen dominance, cortisol dominance, obesity and fat, they're all linked together, right? And so you have to have a complete program to tackle and navigate all of this. And regarding those injectables, I think this is going to be the future of medicine, using 6 hormones versus cortisone for epidural, for intramuscular. I think we need to stop giving cortisone, because progesterone, really, it's more safer, right? And progesterone can convert to cortisone, yes, but it does not have the um, the degeneration effect of the cortisone. And progesterone is the mother of cortisone and the mother of sex hormone, and so progesterone with testosterone in male, injectable for pain application, musculoskeleton. I'm going to push that and going to get the compounding pharmacy on the board on this. This will be a shift in practicing musculoskeleton pain management, and maybe we can stop giving those degenerative drug, which is cortisone, for good. And instead of lidocaine, use procaine. And I think we can redefine the way that we manage pain management safely, adding the platelets nanoparticle or platelets to the equation, loading those drugs and slowly release them and increase or change the pharmacokinetics. And it's more safer when you load them inside platelet nanoparticle. Something we need all of us to work on this. If you need more information, just reach out to me. You know my website, CDPMCS, my phone number, 713-291-6123. I don't know if Audrey is here. If not, if she's here, she can come up with 10 minutes if she wants for her exosomes. If she's not there, if anybody has questions, Mike Emmanuel, I think he's here. Maybe not. Hutan may be here. Those are people who will sponsor our events and hopefully will sponsor Dr. Williams. When you come up with a conference physical, when we can work on that, then I can have those companies, Audrey and Mike Emmanuel and Hutan, to sponsor our event, to exhibit in our events. And we need those companies to sponsor our education program because we cannot make a change in medicine without sponsors. That's what Big Pharma does. And you cannot fight it without having funding going to the education program. So we can have companies funding the education program versus doctors paying membership and fellowship. So we can keep this uh, um, you know, weekly webinars going, whether in my side or Dr. Williams.
Okay,
Is there any questions? Everybody's happy here?
Dr. Hutan, do you want to tell us about your operation at all? Your pharmacy, since we lost Amex?
Hutan and Mike Emmanuel, both of them. Mike Emmanuel is a compounding pharmacy. Hutan is a supplement who produce piriform Bactrim. I don't know if they're both here, but Audrey is here. I don't know. Anybody here from those
Dr.
three?
Hutan's here, yeah.
Go ahead, Dr. Hutan. Let's hear your voice. The piriform bacteria probiotic.
Okay, you're muted though.
Okay, so Audrey is here too, right? If she's here, just go ahead, grab the mic. Hutan, are you there?
He's here, but he's muted. They're muted.
All right. They cannot unmute.
I'm trying. So we got two guests here. So I don't know. Is one of them Audrey?
Audrey and Mike Emmanuel and Hutan. Those are three. Whenever you have physical meeting, we're gonna have them sponsoring it. And I know they're here or not. I did invite
I
them to
see
come.
Hutan, but I did get Dr. Hutan. If you hit your mic. So I don't see him here. Okay. Well, I got nothing here. Anybody got
Okay, he can put his text information and everything in the text.
Mm-hmm. Okay, you just send it to me. I'll make sure to get it to you. And
right.
Can someone hear?
Yep, there you go. There you go.
Okay. Thank you. Sorry. I had to learn technology quickly. So my name is Hutan. I'm a pharmacist, been a pharmacist for 20 plus years. With Dr. Halasa's help, we decided to make, I guess, more condition-specific probiotics based on certain bacteria that have its own role and function. Our first product that's out has to do with weight loss. So we combine probiotics, prebiotics, And then in this formula, we added ginger and green tea. We have 2 other formulas coming out, one for anxiety and one for constipation. Our weight loss product has been working really well, especially with people that are on the weight loss injections. Is helping with their energy level, constipation, and all the other symptoms that they may have. From the feedback we've gotten, people have also had a better weight loss when they were on it, as well as when they stopped taking the injections. I added my information, I believe, on the chat. And if anyone has questions, please feel free to give me a call or send me an email, and I could send you guys any information that you may need.
Okay. Thank you so much.
Thank you.
Dr. Audie, is that her name?
Audrey, if she's here. I
If
don't
she's
know if
here?
she's here.
No?
I don't see her name, right?
Okay.
Okay.
Okay. Great.
Hotan, Mary. Yeah, I don't see any of Mike Emanuel is not here. That's fine. I did my best. I told them to come.
Okay. No, you did a good job.
Yeah, I'm helping them as much as I can.
So next week, just to give you to be on pins and needles, we're gonna hear an opposite view. So next week we're gonna have our incomparable Jay Campbell come on, and we're going to talk about testosterone and not blocking estrogen and the reason not to. So just hold your horses, Dr. Halasa, and just listen to what he has to say first. Okay.
Okay.
So that's next
No
week.
problem. He wants to give estrogen, testosterone without aromatase inhibitor or progesterone. Is that what you're saying?
Yeah, and the AMMG group that's a hot topic. It's been that way for the last 2 years.
So what is the reason for doing that? Do you know?
Well, the main reasons are, estrogen protects against heart disease, osteoporosis, and
Yeah, normal level, not
va-
excess.
vascular blood flow to the brain.
That's true when it's normal. When it's balanced with progesterone, we have normal. But when it's excess and it's and it's then the ratio with the progesterone is very high,
Come,
and that's a different scenario.
come back next week, and you're going to hear, the two of you can duke it out. Okay.
Okay. Well, are you going to be with whom? You, me, or with him? That's the point.
I'm Switzerland.
Huh?
I'm Switzerland here.
I can bribe
moderator.
you. I can give you money. It's come on my side.
That's
Well, I have Dr. Peter Carol is here. No, Peter will be good. Carol, I'll bring Carol with me. She will defend me.
Right.
And Dr. Patel, you're gonna be with me, right?
Yeah.
I'll bring my people then.
We need Dr. Gordon. We need Dr. Gordon on too, because he's on the same page as Campbell. It'd be funny. It'd be interesting.
I will bring my people. I'll bring people.
You bring your people. We're gonna have a rumble.
Yes, we're gonna have a fight here. Yes.
Hi, this is Dr. Clearfield. This is Sylvan Lewis. Can I make a comment?
Sure.
The government did a big study back in the 70s when I was at Bellevue, or 60s, and they were giving men testosterone, and they were dying like flies. They did the study. It was part of a big government study in the 60s and 70s. Why?
What were they giving them? What kind of testosterone? Was it methyl testosterone back then, and it was oral?
I can't remember.
I'll bet dollars and donuts. That's what it was. Methyl testosterone. It was synthetic testosterone, which passes through the liver, which caused hepatic carcinoma. That's why they were dying.
Hello.
Okay, so you know the study I'm talking about.
Can you not find my fridge?
Okay, thank you. Okay, I just wanted to.
Okay, it's in the other room.
Stefan.
Stefan is talking now. We have 26 people. That's a good number, right? 27. Here we go.
Yeah, I think we had over 30.
Okay, that's good. That's a good number. I'm still on 20, so you have 10 ahead of me. I need to figure out how I can get this 10.
Well, we've been getting 35 to 50. So
can you borrow some of your people?
You can borrow. You can borrow whoever. That's fine. Like I said, next week the two of you can duke it out.
Who's that? He's here. Is the guy? Because we're gonna have this, like, the W.
Jay Campbell.
He's here. Is he here?
He's all over the internet. He's
We can do the the way that the WWC, you face them together as a
right.
prime,
We'll put you in a
you
we'll
know,
put you in a ring together. Make it a kickboxing
come up
match.
with some pictures, right? Staring at each other, fisting on each other,
Hmm.
and you're between us. That would be good. That would be good. With some promotion there, whoever B versus whatever. Uh, that sounds interesting. That's how we advance medicine. I like that. And if we don't have the debate and dialogue and conversation, discussion, and it's only one way or the highway, then we have all this misinformation that's going on, right? If you
Hmm.
see there's two doctors. Their name is Peter Hotis and Peter, what is his name, McCullough, right? And Dr. Peter McCullough bet $1 million to Peter Hotz to come up at the debate, and he refused to have that discussion. And of course, the one-way kind of lecture and one way and the highway, and I'm backed up by the mainstream medicine and by the board medical and all that stuff. It leads to misinformation. This one-way kind of education. So we really need to have this debate and discussion, and I'd like to have him, and hopefully, it depends on the crowd here. If and I think the doctors will vote at the end of the day after we
Who's are you
finish
talking
the session.
about? With Peter McCullough, we've had him on a number of times, and
Peter McCullough and Peter
we had
Holt.
him live. That's probably why they threw us out in the first place. They didn't say that, but apparently they had the first meeting to throw us out. I found the minutes. It was the same day that he spoke at our live conference in Las Vegas. So
Yeah, I mean, he's still in my YouTube. I have one YouTube. Still, he's there. They did not put it down. Maybe because they didn't find out. But he challenged Peter Hotis, the guy with the pro-vaccine for the kids and whatever, and he refused to have that challenge, a debate, and he just dropped it. He said no, and don't give him a platform. So, and he come up with a book. It's called Deadly Rise of Anti-Science, right? That's why I came up with my book, which is not yet published. Hopefully, we're going to be republished soon when the health system or systems governments change. So, responding to his book, which is Deadly Rise of Anti-Science, and anti-science is you and me and everybody here, and Dr. Peter McCullough. I respond to it with Deadly Rise of Money-Driven and Safe Medicine. And possibly this book will kind of rectify the book that he's writing.
okay, okay. Any summary, Doctor Halasa? Little wrap
I
up.
think I think I think we need to move forward and change the term of bioidentical hormone to balance it bioidentical hormone, because that word of balance will understand the importance of giving progesterone to antagonize the differentiation effect of excess of estrogen. I'm not talking about normalizing estrogen. If your estrogen is normal, we need that, especially the estradiol. Remember, you said the estradiol helps to increase the high density lipoprotein.
Correct.
Yes, we don't want to completely eliminate estrogen. We need to have the normal level in male and female,
Yeah.
because that will keep the high density lipoprotein high, right? And
Hmm.
if it's low, even you want to give, do you remember when you said we even need to give it estradiol? Estradiol, but very important, he needs to understand there's three kind of estrogen. There's estradiol, which is produced by the gonads mainly. There's estrogens, which are produced by the fat, which is the bad ones. And there is estriol, which is produced by the placenta during pregnancy. So I'm talking about the bad of the estrogens, but estradiol, we need to keep that as much as we can produced from the gonads. And estrogens, excess of estrogens can lead to inhibition, feedback of the hypothalamus pituitary gonad, and can decrease the estradiol. So excess of estrogens can eventually feedback and inhibit the estradiol, which we needed for increasing the low density, the high density lipoprotein. So I'm with that doctor about maintaining the normal of estrogens, but I'm talking about estradiol, not excess of estrogens.
Got it. Okay.
And
All right.
then the other thing is that it's about changing the injectables. If we can change the injectables to progesterone and estrogen and testosterone and progesterone for musculoskeletal pain application, and we already have a study that shows that progesterone is more effective than cortisone in managing carpal tunnel syndrome. If we can change that, that protocols, all of this pain management, that will be a great movement. And I think Dr. Sylvian agree with me, right? Dr. Salvis, are you there? He's not there. I think he left. Okay.
Okay. All right. Before we go, if anybody's interested, I have a kind of a puzzling case, and I was wondering, if I don't mind me switching gears a little bit. If anybody would like to chime in, and I'll give you the sort of a brief history. So, his name is Eric. He's 45 years old. In December, he had gotten a cortisone shot for tendonitis in his shoulder. He says he immediately experienced numbness on the other side of it was his right shoulder and the left side of his face, with vertigo and dizziness. And he stated that he didn't it hasn't abated since. So he's had this for 2 months now. He was my patient a number of years ago. He moved to Oregon, and I haven't seen him in about probably in about 2 years. But he did call on the phone. It was actually while I was away, and they sent me all these records. And there's a couple of interesting things in here, and one of them that I'm not really sure about and familiar with. So we had a CAT scan of the head, and it showed microvascular compression around the trigeminal nerve. So that might explain it. But why would he get it right after a cortisone shot? He had a CAT scan of the neck, and which was basically negative. He had a CAT scan of the abdomen, or an MRI of the abdomen. For some reason, that was normal. Most of his laboratory studies are normal, except one that sort of stands out, and it's thyroglobulin, which is 43, which is very high. And so, not anti-thyroglobulin, not thyroid antibodies, thyroglobulin.
So
So
that's meaning he has inflammation, Hashimoto thyroid. Something is breaking his thyroid.
right. So the only explanation that I've ever found for that is thyroid cancer. Now he had a CAT scan and an MRI of the neck. They didn't mention the thyroid at all. But his thyroid function is normal. His TSH is 1.7. His free T3 was 3.7. The scale they use is 0 to 60 for the thyroid antibodies, and they were normal. And reverse T3 is a little bit high on my scale, with 17, which is in the normal range, but we use that as a proxy for cortisol or stress hormone. Anything over 15 is usually positive for a cortisol abnormality there. They didn't do a cortisol test itself. So cholesterol is 242 total. Everything else is pretty much normal. And vitamin D was 30.
There was a question in the chat. Did he get the jab, Doc?
I don't know. So that I don't know.
Yeah.
So, but why
Doctor,
would a Kenalog shot set it off?
let me come up here. I had thyroid cancer, right? And do you know that the CT scan did not show anything? And yes, I have thyroglobulin was high, and the only thing that shows up when I did PET scan, and they don't want to do the PET scan because I've not been diagnosed with cancer. And then they did the PET scan, and I came up with cancer. So in those suspicious cases, if you think there's something wrong, just order the PET scan, because that will show. Even the iodine scan did not work. But anyway, I'd like to introduce the pharmacist. I think he's here. Mike Emmanuel, are you there?
Yeah, I'm here, doctor. How are you?
Can you introduce yourself as a source of, you're going to do balanced bioidentical hormone, and you want to make sure when you prescribe to the doctors, you aware them that they need to add progesterone to testosterones and possibly some aromatase inhibitors in case. If you start as a compounding pharmacy, then all the compounding pharmacy will copy, of course, but eventually you'll be leading this balanced bioidentical hormone.
Yes, for sure. We're going to let them know. I'm going to post my email address if anybody's interested.
Your cell phone number. Let those doctors reach out to
Yeah.
you. A person
I'm
over there.
Yeah, I'm going to send
Okay.
my cell phone house.
Okay, and if I think we need to have this movement and push it because once the compounding pharmacy is successful, then all of the compounding pharmacy will be successful too.
Yes, sir. Yeah.
Any other questions? In your case, Dr. William, if you suspect there's any suspicion that it's cancer, because yes, when you have destruction of thyroid, it releases thyroglobulins, and I think it's more worse to see thyroglobulin than antibodies, because even there's no time even to develop antibodies. Then you may need to consider PET scan.
Okay.
That would be, and you know how much centimeter my cancer was? It was 0.5 centimeter. 0.5 centimeter, less than 0.5 centimeter, less than half a centimeter. Okay, and it's only be detected by PET scan. You can see it's lighting up, because of the glucose absorption. And I remove all my thyroid is being out, and then they remove one side of my lymph nodes, which is called the lymph node dissection, neck lymph node dissection, and they left the other one. But I did not feel good after 3 months. I feel there's something wrong my other side of my lymph nodes. And what I did, they say, oh, everything is fine. I say, no, there's something wrong. So they did biopsy and they find something in my left side. So what I did methylene blue for the dynamic therapy. I was swallowing methylene blue and putting light on my neck, like 3 months before the surgery. And when they did the surgery and they removed all the lymph nodes, they did not find cancer. They find the lymph nodes abnormal, like hypoechoic, which is empty lymph node, liquefied, but there is no cancer cells. And I think that lymphodynamic methylene blue photodynamic therapy did have effect in destroying the cancer, but destroy the cancer and but still those lymph nodes is like a little bag of sack of fluid, but they did not find any cancer cells in it. So something you may consider, using methylene blue photodynamic therapy for those cases and generally for any cancer.
Okay. Okay. Thank you all. Thank you. Anybody else? Anybody have any questions or comments or anything else? Any questions for Dr. Halasa?
Are we all happy?
We're all happy.
Meet for next week.
We're all happy. Next week, Jay Campbell. You guys will duke it out, and then the week after that, we're going to have a fellow named David Silva who does financial planning for medical personnel. So a little bit different, but that's an important aspect. And a lot of us struggle with the business end of medicine. So we're going to have that in 2 weeks. Okay. Again, anybody wants to present anything, please let me know. John, how's it going?
Can you hear me?
I hear you.
Oh, everything's going good.
Is that Dr. Sylvia behind you there?
There's
Yeah.
there's the brain.
Yeah.
There's the brain.
Is the brains of the operation? How's the medical school?
Everything's going extremely well. You and I should
Can't
have.
hear you.
Am I gone again?
Can you hear?
We can hear you. You're just not loud enough.
All right. How's that? I'm yelling.
Try it again.
Where's your volume?
So now I can't hear you at all.
No.
There you go.
Okay. Now you can hear me.
I can hear you.
Okay. Everything is going extremely well. I didn't have time to tell you last week. The guy who is the genius researcher who worked with us before just left his university position, and he's just an incredibly humanitarian good guy. So he may work with us, which is extremely good news, because I think sooner or later this group is going to have to deal with that silly research stuff, and we can do that. So that's the good news.
Mm-hmm. Okay, great. Okay, anybody else? Dr. Quinn, how are things in your world?
You're muted, Dr. Quinn.
Okay, well,
Everyone has trouble talking.
now we know who pays attention, right? So, okay. All right. Anybody else? So we're coming up April 10th to 14th is AMMG. in Miami. I'll be there. Stefan, you going to be there?
No, I'm going to be in Italy,
Oh, well, that's better than Miami.
but I'll be at the one next week in A4M.
No. So I was with Dr. Halasa with Dr. Farshian last week. So that's enough traveling for 1 month. So
I bet.
okay. So take notes.
All right.
Okay. All right. Anybody else? Comments? Questions? We're still working on this platform here, so I'm doing my best. So and it says okay. So Dr. Hutan put his cell phone number here and his email. He's got a probiotic formulated weight loss tablet. So okay. So we got that. 702-712-1461. The videos will be up on aosrd.org/webinars and also on Clearfield Medical Group YouTube channel. Okay, it'll be there also. Okay, so there you'll find the videos there, or if you can't get lost, just give me a call. So this is Mike from a national pharmacy in California, and I've been using them quite a bit. And they're actually in my EHR, so they're not hard to find. And they've been doing a great job for us, so we like them a lot. So unsolicited there, Mike. So okay. Somebody raised a hand. Whoever it was, speak. So I don't know.
I think we're good, right?
We are good. Thank you
Yes.
so much.
Okay. Well,
Dr.
good night,
Foster, as
everybody.
always.
See you next
Yeah.
week.
Okay. See you next week. Same time, same station. Jay Campbell.
Yeah, and just promote that. You know, the WWC between me and that other doctor. What's his name? Doctor, you said
Jay Campbell.
Jay Campbell. Okay,
Yeah.
me, Dr. Campbell, and you're the moderator, right?
He's rather opinionated.
Okay. How old is he?
He's 52.
Okay, he's my age, so I think we're good. Weight, I think he's not the same weight, right? You think?
No, he's pretty lean. He's in good shape. I don't know
Good
about
shape.
you, but he's in good shape.
Well, I have Stefan in case I need some.
Okay.
His biologic age is 26.
Yeah.
All right. So, but I have Stefan. I'm not worried.
Okay.
All right.
All
I
right.
can
We'll
help.
be in
Right,
touch.
everybody. All right. Say good night
Yeah, everybody. Okay,
and
bye.
take care.